Welcome everyone to the first webinar as we kick off the third day of the virtual SMA Conference Week. This is Sarah from Cure SMA's Family Support Department. Thank you so much for joining us today. We would also like to thank our national presenting sponsors, Abexis, Biogen, and Genentech, for their generous support of the 2020 virtual SMA Conference. We would also like to recognize the support of our visionary sponsor, Ionis, our platinum sponsor, Scholar Rock, and our silver sponsors, Accredo and Promobile. We appreciate all of the questions we received in advance of this webinar, and we'll try to answer many of these during the presentation. Please note that all lines will remain muted during the webinar, other than the speakers. We would now like to introduce our speakers, Tina Duong, a physical therapist at Stanford University, and Dr. Bakri Elsheikh, a neurologist with The Ohio State University. They will be presenting on medical management of adults with SMA.
Good morning. Thank you everyone for joining us today. It's really my pleasure to talk to you today together with Tina. So unusual times, and so we're doing the workshop this year virtually, and I hope you guys are all going to enjoy it, and we'll have some good time talking about medical management of adult patients with spinal muscular atrophy. The first slide is showing our disclosures, and those are related to grants, study supports, as well as advisory boards and consultation. Next slide, please. So here is the outline of our talk today. So I will start with a brief overview of the presentation and diagnosis of spinal muscular atrophy, with a special attention to the adult population. Then we will talk about the standard of care management, and then we will talk some about the current FDA-approved treatment for the adult patient, and lastly we'll talk some about what's in the pipelines for the adult patients. So next slide. Well, as you all know, that the spinal muscular atrophy, which abbreviated as SMA, is an inherited neuromuscular disease with degeneration of the motor neurons. Those motor neurons are sitting in the spinal cord. This results in progressive muscle weakness and atrophy, and hence the name spinal muscular atrophy. So SMA has unique genetics. The main reason of the disease is really SMN protein deficiency. That refers to survival motor neuron protein deficiency. So the SMN protein is coded for by two genes, the survival motor neuron gene 1 and 2. We refer to them as SMN1 and SMN2. The product of the SMN1 on the slides on the dark red on your right side is a full functional SMN protein, whereas the product of the SMN2 gene, which we like to refer to at times as a spare gene, is missing what we refer to as exon 7. This is only able to give us around 10% of that full-length functional SMN protein. So what happens in individuals with SMA? That main gene, the SMN1 gene, is either missing or mutated, and basically they depend on the SMN2 to produce a small amount of that full-length protein. So deletion or mutation of the SMN1 with retention of the SMN2 gene as a spare gene, with an ultimate result of SMN protein deficiency, is what causes the disease. So next slide, please. There is quite wide variability among individuals with spinal muscular atrophy. So we know that the disease affects all ages, and traditionally it was classified based on the age the symptoms start of symptoms onset, as well as the maximum function achieved. We've heard about type 1, 2, 3, and 4, and again, they share all the, they're all characterized by weakness. However, the earlier age of onset in the disease and the lesser function attained refer to severe forms of the disease. The natural history of the disease is really changing. There are several reasons. There are implementation of the proper medical and supportive care. There is early detection of the disease with newborn screening. And also there are treatments that are disease or gene modifying therapies, and those were transformative therapies that helps change the landscape. So majority of patients with or individuals with spinal muscular atrophy will live into adulthood. And next slide, please. And that's really what we see in the adult clinics. And so we like to think about adult patients that we see in the clinic as one of three categories based on their function at the time of evaluation, whether they are still ambulatory or non-ambulatory. We divide the non-ambulatory group to a severe form of the disease where they are not able to sit independently, and those previously or traditionally classified as type 1 and 2, they tend to have very severe weakness, facial and bulbar muscle weakness. They tend to have scoliosis, previous surgeries, and they tend to have severe respiratory compromise and need for ventilatory help, or at least BiPAP treatment at part of the day or the whole day. The middle form is non-ambulatory, who retain good strengths, but they do have very significant weakness on the proximal arms and muscles. Their legs tend to be way more involved than the upper body, and they tend to have less complications compared to the first form. Whereas the milder form of the disease is the ambulatory individuals who are still able to walk. They still have some significant weakness on the proximal arm and leg muscles, but they tend to have less problems with the complications in terms of the respiratory function or the facial muscle involvement. Next slide, please. That being said, I picked up this graph from a study by Wadman et al. That looked at muscle strength and motor function using cross-sectional approach to investigate a cohort of 180 SMA individuals. However, 108 of those were adults over the age of 18. So the slide is just to show that there is a progressive decline in both motor function and strength in all individuals with SMA and all types of SMA. Those patterns may differ based on the type, but SMA is a progressive disease with loss of function and strength over time. Next slide, please. So the loss of function and the loss of strength is sort of mainly because of the disease itself, causing the degeneration with muscle weakness and atrophy. But there are other variables and factors that contribute, including the aging process and inactivity. That makes physical activity and exercise essential in minimizing strength loss, secondary to disuse and inactivity. I will turn the microphone to Tina to talk to us a little bit on the next step about the standards of care management.
Great, thanks, Bakri. So I really do appreciate this is one of our favorite talks that we get to do together, Bakri and I. And so the next few minutes, I'll talk through. Next slide, please. The kind of some of the standards of care management, but from particularly from a rehab perspective in regards to the medical management and how we can do combination therapies, addressing strength, exercise, etc. So next slide, please. So I know that we have a wide audience here, and so I just wanted everyone to know that in the standards of care, it's we do promote a multidisciplinary approach. There are 2 papers that were published more recently by a group of experts consensus on what the standards of care should be. And as you can see here in this figure, that the center of all care should be you, the patient. And the most complex part of, I think, having SMA is that you have to coordinate your care. So hopefully, if you're not at a center where they have a multidisciplinary team in which there is a nurse coordinator or someone to help coordinate, then you have to do a little bit more of that on your own. And so we hope to give you the resources to be able to coordinate and pull some of the clinicians and professionals together to ensure that all the appropriate organ systems are addressed as you're getting older and being and an adult with SMA. So one of the primary things that we want to make sure that you're thinking about are not only the pulmonary respiratory aspects of SMA, but if you had to go to the ER and different types of management, other organ systems, nutrition, orthopedic, rehab, all of those things have to play together in order for good coordinated care. And of course, every time I say this, I hear the one individual that says this is a unicorn in adult care management. But I know alongside Cure SMA, we are aware of that and trying to provide the most amount of supports possible to help more centers get up and running from this perspective to make management of healthcare with SMA a little bit easier on you as an adult. Next slide, please. And so really, as what are the benefits of going to adult providers? The transition of care is difficult, and this is not isolated to SMA only. When you have a chronic disease that encompasses from pediatrics to adult, how do you transition that? And we're not going to specifically talk about that today because that could be a whole talk on its own. But we want to emphasize the importance of going to see adult providers, because with adult providers, you could be screened and managed for adult diseases and age-related changes. So just because you have SMA doesn't mean that you're immune to all the rest of the stuff that we have to deal with aging, such as loss of muscle strength and mass because of basic sarcopenia of aging. So we want to make sure that, with SMA and with aging, how do you manage that to have the healthiest lifestyle you can? And then for the women, there's a talk tomorrow about it, but addressing women's health issues, those are really important and difficult for women without disabilities. But then when you have it, how do you find the appropriate provider that has the appropriate equipment for you to safely and feel most comfortable to manage women health issues and sexual health issues? And of course, it's important whenever you do have to go to the hospital that you're admitted into adult hospital so that they can especially give you the appropriate respiratory treatments as needed. And then in regards to resources, as adults, you need different resources than kids do, right? And so there's vocational rehab, job coaching, etc., that is useful whenever you do see adult providers, that especially social workers who are oriented in the adult world could give you resources that could help make life a little bit easier in regards to the work-life component. Next slide, please. And so that being said, I do want to point out the differences in health and wellness. Health, according to the World Health Organization, or the WHO, is a state of physical, mental, and social well-being. And it's not linked necessarily to absence of disease or having disease. And so when I talk about health and mental, social well-being, that's really what we're talking about. While wellness is really, once there's a treatment, there tends to be a trend to look at how can you make better choices for a healthier lifestyle. And so that's kind of the difference when we speak of health and wellness. Next slide, please. And so that being said, with the new treatments available, what happens in the rehab care model before, it was, what Bakri showed was that, in adults, there's been arguments that you stay the same or there's slight plateau. The truth is none of us stay the same. As we get older, we all have to work a little bit harder to stay healthier, to keep our muscles strong. So, we all have to do a little bit more strength strength training as we get older because we naturally lose some muscle mass and force, right? And so what's happened in this care model now is really called what we look at in the rehab world as habilitation, where you work to acquire, keep, or improve the skill sets that you do have. And this is a ways and has its ups and downs depending on life circumstance, but that should be the approach in which your healthcare professionals are trying to work with you to achieve the highest independence that you may have for your activities of daily living, as well as your social and work needs. Next slide, please. So in this changing paradigm, in this natural history, we're all learning together. And so with new treatments, you have a new phenotype. Bakri mentioned the 3 phenotypes that are happening, but I'm sure you know, we as a community are constantly talking about, is this sufficient? Describing SMA 1, 2, and 3 may not be the best way for all of us to understand what that means with this changing phenotype and new treatments available. And so with this paradigm, we go from a reactive care. So reactive is basically, if something happens, we'll take care of it, versus a proactive care. So we become more preventative medicine because you want to prevent the downstream effects of inactivity, of muscle loss. And so that should be the approach when you talk to your rehab professionals. And so for those of you who don't see a multidisciplinary clinic, you may not be fully aware of what physical occupational speech therapy may offer you as you're going through some of these treatments. And I know that everyone who's on treatment or not are keenly aware of what you would like to improve. And so I'm just giving a brief overview here of what, in general, the buckets that fall under PT, OT, and speech. So in PT, we typically work on functional strength, gross motor skills, and musculoskeletal health. While occupational therapy tends to work on the fine motor tasks, assistive technology, and ADLs. That being said, it does not mean that each one of these boxes are black and white and concrete. We all do work together to ensure that you get the best combined care. And then, of course, a lot of adults have been asking us about speech because there may be some changes in speech and improvement in speech with treatment. And you can definitely get an evaluation and work with a speech pathologist on working on articulation, voice production, speech, facial muscles, and activation. Because all of this with chronic SMA, you may have muscles that have been asleep for a while, and all of these rehab professionals can help wake up some of these muscles that need to be reminded that they're needed and needs to be working. And then these therapists have a lot of tricks to ensure to wake up those neuromuscular fibers. Okay, next slide, please. Great. And so in the combination therapy, what are we looking at to increase strength, function, and independence? Of course, the medical treatments, which Bakri will talk about at the end of our presentation, but exercise, including strength, aerobic, and stretching. Right. And then with musculoskeletal health, maintaining the extensibility of your muscles itself. What can you do? And then alongside that, you have a lot of assistive technology, mobility, bracing, robotics, and exoskeletons to help achieve your goals. And so it does take a village, and combination treatments is really where we need to go to help you meet your goals. And so I know there's a devil in the details of all these things. It's a lot easier said than done to do it. So I hope to give you a little bit of information to help at least get you started and have a conversation with your professionals at home. Next slide. Okay, so first we'll talk about contractures. Next. And really, when we talk about contractures, it's everyone asks, what really is it? It's really abnormal shortening of either the muscles, the skin, or the connective tissues that restrict your range of motion. And this is caused by different things, such as positioning. So if you can't move your muscles throughout the range, you're sitting in one position, your muscles may end up getting, quote unquote, stuck in that position, right? And this is a combination of the strength imbalances. As we know in SMA, there are strength imbalances where your flexors are a little bit stronger than your extensors, and because of that, that may cause some shortening of your connective tissue or muscle, and then weakness, and so resulting in physiological shortening. So the purpose, next, of management is to improve the muscle length, and so for that, that's really if a muscle is truly contracted, it's not moving at all. It's really for tight muscles, and if you can imagine, if your muscles are weak and you need to overcome that with strength, if it's tight, then you have to work extra hard. So you want to make sure that you're maintaining that extensibility in preparation to working on strengthening. And of course, we want to prevent any kind of orthopedic deformity, so you can avoid possible surgery. And a lot of times contractures also result in pain, so we want to make sure that we try to be preventative in that fashion, and of course improve function. Next slide. And so then that being said, I'll quickly talk about exercise and really an active lifestyle. Next slide. Okay, and that being said, I can't talk about exercise without talking about the muscle length tension relationship. Next. And that being said, muscle fibers don't produce the same force throughout the entire range. Who knows that better than everyone here that's on the webinar right now? It is important to work through the entire range of motion, but when you have weakness, that may not be as easy. So you have to have someone, or you can identify the areas that are weaker and the areas that are stronger, and you may need assistance through some parts of that range of motion so that you can work the weaker parts. And that may be using assistive technologies, or could be as low tech as having a wand, pulley systems, and bands. So your therapist can help work through what your goals are to ensure that you're working that entire range of motion. Next slide. And so then when we talk about standards of care, the guidelines for SMA is divided into strengthening and aerobic exercise. But what does that mean if you have some muscle weakness? We talk about concentric and eccentric exercise, and the focus is on working on the proximal, distal, and core muscles. What the guidelines really say is that your muscles have to have at least anti-gravity strength, meaning, for example, here in the biceps, you're able to move your arm against gravity's force. Right? If you're not able to do that, strengthening is not recommended, because then really what is it doing? It's just keeping you in that one position. However, if you don't have anti-gravity strength, we've had some patients, for example, biceps, you do a bicep curl, and this is what you do. If you can't move your hand against gravity, you can turn it and put your hand on the table, and this is what is called gravity eliminated. So then you work through that entire range, and as you get stronger, then you can move into more anti-gravity. So exercise is all about monitoring progression, and your therapist can help you with that. A lot of adults have questions about resistance and neck muscle strength training. And so really what you want to do is to make this functional. You shouldn't add resistance to doing neck muscle strengthening, but you could work on on neck and trunk stabilization. Okay, and so that means co-contraction of the muscles around the joint. And then of course with aerobic exercise, there's swimming and activities that you could do in wheelchair sports, and there's a lot of wheelchair dancing that's kind of cool and neat. The duration that's recommended is 30 minutes, and this should be done 2 to 3 times a week, but optimally 3 to 5 times. Next slide. So this, I just wanted to point out, this coincides really well with the 2018 physical activities guidelines, in which they do recommend that you do 2 hours and 30 minutes of exercise of moderate intensity, and that coincides with the standards of care guidelines. Next slide. And so according to the physical activities guidelines as well, they do talk about for people with disabilities, if you're not able to do that, start slow and work it up. The real goal here is to avoid inactivity. So don't let those numbers that are minimally required and suggested scare you. If you're not doing any activity, let's just work up to it and give yourself successes along the way. Next slide. And so the goals of exercise is to avoid the disuse atrophy that Bakri talked about, not necessarily to rebuild muscle, You're training to maximize function, so that's why you need to adapt as needed. And of course, with energy conservation, you want to watch for fatigue and overuse. Overwork may lead to extra weakness, so make sure that you are in touch with your therapist as you're doing progression to ensure you don't have overwork weakness of your muscles as you're strength training. And of course, consider good biomechanics because of the muscle imbalances and hypermobility, you're at increased risk of getting secondary injuries. So you want to make sure that doesn't push you back in your exercise goals. Next slide. So in your exercise program, so you'll just click through these, there's flexibility that should be a part of your program. That could be stretching or just passive range of motion, strengthening, and that does include trunk stabilization. And remember, strength training is usually high resistance and low reps, right? So high resistance meaning at least 8 reps. And then endurance and cardiovascular is low resistance and higher reps. And then we don't really talk about it, but you should talk, but balance is a very functional activity that should be added as part of your program, whether you're ambulatory or non-ambulatory. And that's about co-contraction, trunk stabilization, and weight shifts, so that you can manage how your body moves as you shift your weight from one leg to another, or shift your body from one side to the other to do reaching and upper extremity activities. Next. So the training program should fit under the FIT principles. And what that means is the basic requirements that you should have as part of your program that you can monitor. And F stands for frequency, that's how much. I is intensity, is how hard you're working. Time is how long. And type is what type you're doing, okay? And so what you, next slide, I'll talk about intensity. So people always ask, how do I monitor intensity? And the easiest way to do that is the talk test. So really, it's if you should be able to talk, but you can't sing during the activity. And it's just start building up your activity based on this. If you want something a little bit more objective or numeric, you can use a rate of perceived exertion scale. And moderate activity, go ahead and click, is a 4 to 6. And so you can see here, 4 to 6 is the same as the, you can talk but not sing, okay? So next slide. And so I'm going to end with a few just examples, just kind of walking through what a progression may look like. And so we'll, I'll have you click through this as well. Here is trunk stabilization. So this individual, she started off with the ability to sit using a vest. Next, she was able to sit without a vest using upper extremity yoga blocks to help hold her up. And then as she progressed, she was able to independently sit. And then when she was able to do that in a certain amount of time, so they measured intensity by time, they added some perturbations. So kind of pushing her a little bit to get her to activate different aspects of her muscles. And then as she got stronger, they added the ability for her to use her arms. So these are examples of small goals that lead to a larger goal of sitting that, that may be relevant to you. Next slide. And then people also ask about knee extension. So what I want to talk about, those are your quads. And the easiest, the less intense knee extension exercise is open chain, meaning your feet are not planting the ground. So you can start without weights, then you can add weights. But the most functional aspect of strengthening for your knees is closed chain. And that means your feet are on the ground, and then you are working with your feet planted. And as you can probably see in this picture, that as the surface gets higher, it's easier to get up off the ground. So this is where you can moderate the progression as well. And then if you have, like we talked about the length tension relationship, if you can get most of the range of motion, but you can't get towards the end of the range of motion, you can work harder at the parts where you're weaker, such as this example, or next click. You can also have somebody assist you in that in range, because I know a lot of people have a hard time getting that last, 25, 30 degrees of full extension. And if that's where you're lacking, make sure that you are working that, because the transference of skill set is based on what exactly that you are doing, and it's the specificity of that training. Okay, and then lastly, we recommend monitoring your treatment or your exercise with a exercise calendar. So this is an example of something that we use at Stanford that has to fit parameters in identifying what kind of activity, how long, and what you're doing, and the intensity, so that you can work with your therapist, your personal trainer, so that they can help you progress according to what your goals are and your health state. Okay. And there's a few ways of doing that. And so there's outcomes that should be used if you're getting treatment or if you're not getting treatment. These are just an example of motor function tests that have been used or validated in SMA. And I'm sure many of you heard about 6-minute walk test, Hammersmith, MFM, the RULM to look at upper limb, the A10 that is a wheelchair only assessments. Those can be done to look at motor function. Strength tests may be assessed by manual muscle testing, how hard you push and pull against your provider. And then handheld myometry, which is typically done with something, for example, here's the microfit. Different instruments have different sensitivities. So for example, the microfit, it measures muscle strength up to 0.9 pounds. And so if you can push 0.9 pounds, it's able to measure that. So make sure that whoever is doing the muscle testing, that they have an instrument that's able to measure in that sensitive manner. And of course, range of motion and measuring contractures could be measured by this goniometer. And then exercise tolerance testing can be done to have a baseline of where you are from an activity perspective and how you utilize oxygen. To monitor and start any of your exercise activities. And last but not least, speech and swallowing, so they could work further on voice production, articulation, and possible jaw range of motion. And so that being said, I'll hand it back over to Bakri to talk about some of the current treatments in the pipeline for SMA in adults.
Thank you, Tina. This is really, next slide, please. So I think that was a great leeway into the actual treatment strategies that we could use for treatment of SMA, a particular attention to the adult patient population. And so if you look at the figure, so there are several ways to treat SMA. Some of those are already in the clinic, and some of those are in the research pipelines, and they're being tested. So the top figure is showing you that as we talked earlier, that you might lose the SMN1 gene, and that's the main gene. So giving that back gene through using a virus vector is really what we refer to as the gene therapy, and that has been successful and was approved to treatment in the pediatric individuals with SMA. Whereas the strategies to help increase the SMN protein coming out from the spare gene, which is the SMN2 gene, include two major ones. The one is using antisense oligonucleotide, and the other one is using a small molecule, which is a splicing modifier. For the antisense oligonucleotide, this is nusinersen or Spinraza that's made it to the clinic and is FDA approved. The small molecule is risdiplam, and I'm going to talk about that some more. There are other strategies that are actually being tested to augment the treatment that work directly on increasing the SMN protein that's missing. Treatment that looks at neuroprotection at the level of the motor neurons. There are medications that work at the muscle level, and there are a couple of those that's being studied. Next slide, please. So this is actually just to show how the FDA-approved treatment, which is nusinersen, help include that missing exon 7 to increase the SMN protein and help with the weakness that's experienced by patients with the SMA to improve strength and to improve function. Next slide, please. For approval of the treatment, particularly for the adult patient, there are several steps that are needed to get to the point of treatment. This is include collecting clinical data as to how long you've had the disease, when did the disease start, and most pertinent for the adult patients is to see if they do have any of the adult diseases that Tina was talking about earlier. And so, do you have diabetes? Do you have high blood pressure? Whether there was a history of clots? Are you using any medication that can interfere with the delivery of the treatment? So, and then we go through a pre-authorization process to get approval for coverage or approval for enrollment in a free drug program. And most importantly is we need to perform assessments at baseline and subsequently to figure out if the treatment is making a difference in terms of the motor function or the quality of life, or using some of the biomarkers in the electrophysiology or the EMG lab, as well as the lung function, as Tina mentioned earlier. And so another thing that has to be planned or pre-planned is many of the adult patients who are non-ambulatory might have had scoliosis and might have had spinal fusion, which makes the delivery of the treatment through a lumbar puncture a challenge. And so alternative routes are being tested, whether it's through fluoroscopy guidance or CT guidance, whether they are using certain implants or via using cervical injections to get access to the intracerebral space. And then, as I said earlier, we need to monitor for any side effects related to the medication. There are blood workup and urine tests that has to be done prior to each injection. And then there are assessments to help for continued approval. Next. So the good news is, compared to last year, is we are seeing some data that's coming out regarding using the nursing treatment in the adult patients. Most of these are real-world data, but it's really very encouraging. And so this is, I'm not going to go over the details of each of those studies, but I will highlight them. So this is a study from the Rochester group that has 12 patients. 75% of those patients were non-ambulatory with history of scoliosis, and 4 were in the adult range above the age of 18. And it did capture the subjective improvement of endurance and hand strength and power function that we do hear from a lot of you who are on the treatment, as well in some of the motor function assessments that's particular to the upper extremity. Next slide, please. Another study that came out that looks at the type 3 adult patients, and also shown that the treatment is well tolerated with no serious adverse events. There are side effects that are occur which are related to post-procedure headache or back pain, but also this treatment was for 10 months, and it's also showing some mild treatment effect using some of the outcome measures in a subset of patients. Next slide. The largest trial that came out is really a trial that came out from Germany. It was first authored by Tim Hagenacker, and it was recently published. That study was able to analyze 124 patients who received treatment for up to 6 months, and at 14 months they've had up to 57 patients, and the patients are of various disease severity. as well, they were having different numbers of SMN2 copies, and the average age for that studies in the 30s range. Next slide, please. So this is again looking at the adverse events, and the most common ones, as I mentioned earlier, is the headache, back pain, and nausea that's seen and most likely related to the procedure itself. Next slide, please. So this is really where I wanted to show that there are several of the outcome measures that were showing encouraging results in terms of motor function or 6-minute walk test in seen in the majority of the patients. Again, this is real-world data that's showing that there is safety and efficacy of the treatment, and there is improvement. There was greater improvement in those who had lower severity at baseline, but it was seen even in some who had more severe form of the disease. Next slide, please. So I will next slide. So I will move to say a couple of things about what's really in the pipelines. As you could see from this figure from the Cure SMA, it's really, there are a couple of drugs that are already made it to the clinic. One of them is approved as for the adults. There is one that's being currently reviewed by the FDA for treatment of SMA. Next slide, please. So the gene therapy, or the ensemble gene, or known as Zolgensma, is yet not part of the medications that we could use for the adult patients. It's approved for children under the age of 2, and there is some recently encouraging data for children up to the age of 5 with 3 SMN2 copies, and this time the treatment is delivered through intrathecal injection rather than IV injection in the babies below 2. Next slide, please. So the oral medication is the risdiplam is really what the FDA is currently looking at for approval. Most recently, we've had data from the Sunfish study that included both type 2 and 3. It allowed patients up to the age of 25, both ambulatory and non-ambulatory, and there was some significant improvement in patients who are receiving treatment versus placebo with regard to the functional assessment that's used as a primary endpoint. There is another study that's also ongoing, that's also including adults up to the age of 60. That study allowed transfer of patients who are already using nusinersen if they have a wash period of 90 days. And so we're looking to see more of those results to be able to analyze the data pertinent to the adult patient population. Next slide, please. And so there is also another trial that's ongoing using nusinersen at a higher dose, and by Biogen. That's a DEVOTE trial. What's pertinent to adult patients is really a part C of the trial that will allow enrollment of adults over the age of 18. However, there has to be ambulatory and previously treated with at least 1 year of nusinersen. The dose they will receive is really a higher dose. Instead of the regular maintenance dose of 12 milligram, they will get a 50 milligram, and subsequently their maintenance dose will be 28 milligram. So we're also looking forward to the result of that study to see if more of the drug is going to make a difference. Next slide, please. So the thinking about the therapies and treatment of SMA, and this bring me back to re-emphasize what Tina talked about, the importance of the standard of care in terms of physical therapy, rehabilitation, care for respiratory system, good nutrition, handling orthopedic problems. All of those are really the main pillar for any treatment for care of patients of SMA. Now, particularly the adult patient. So there are two therapies, and the thinking is probably going to be more than combination therapy. The main therapies are SMN dependent. We talked about using of ASOs like the nusinersen, or using small molecules like the risdiplam, or the gene therapy if it, replacement therapy, in addition to other medications that helps with neuroprotection or work at the level of the muscle. Next slide. So here are the take-home points is really as the most important thing is really you have to take an active role in your care. Really use the standard of care document. Those are valuable documents. You can use them to share with your local neurologist and primary care physician. This will help them with your care. We believe the best is really to get your care in care centers that are having multidisciplinary team that will allow you to have, for the most part, one-stop shop to get your care. Exercises really can add benefit to the medical treatment. And for now, FDA approved nusinersen for SMA of all ages and all types. And there is good emerging data about its efficacy as well in the adult patient population. The risdiplam is the oral molecule that's undergoing review by FDA for approval. We're expecting to hear sometime late in August. Most of the currently approved treatment are high priced, and that might represent a hurdle in access to treatment for all individuals with SMA. There is still gaps in knowledge and much more to learn about the disease. So consider participating in research studies to help address those gaps and to help optimize treatment for individuals with SMA. And I thank you at this stage, and I turn the microphone back to Seth.
Thank you so much, Dr. Elsheikh and Tina, for that great presentation. This is Colleen from Cure SMA, and we just wanted to address a couple of quick questions from our attendees. The first question is, are there any tests that you would recommend for adults with SMA to measure ability and strength over time?
So if you want to take a look at the outcomes slide that I went through, so this is we understand now that there's gaps in some of the outcomes that we have to measure strength. So in general, it's hard to answer that question without knowing specifically what your functional level is. The strength measures that I indicated for strength are some of the handheld myometry that your therapist can measure specifically for you, depending on what your musculoskeletal health looks like. As long as they're consistent, what you're really looking at is not really necessarily comparing to what was published, but really following your own progression. So they could use like a handheld myometer like the microfit to measure strength. And also they could possibly look at manual muscle test and active range of motion. Active range of motion just says how much of that range you're able to lift by yourself using your own muscles. And that is also an indicator of strength. So there's various ways that strength could be approached. And then motor function measures, as Bakri mentioned, some of the studies have used the Hammersmith and the RULM. So those are motor function tests, but there are other ones that are being utilized, such as the CHOP A10 or the A10 for people who are weaker, that's able to measure your progression over time. And so the thing to keep in mind is there should be something that's measured, and it should be consistent with a consistent person doing it for each one of your assessments, so that you can compare and look at your own rate of change.
Great, thank you. Another question that we have here is, are there adult hospitals that are considered SMA-friendly hospitals?
Well, absolutely. There are care centers that you could look at the SMA, Cure SMA website for the map to see some of the care centers. And there are also, you can also use the NDA care centers as well, if as another source for treatment of patients with SMA. What we're really looking for is multidisciplinary care centers that individuals are able to provide, to familiar with the disease itself, but you are able to see your physical therapist, your occupational therapist, your nutritionist, and respiratory therapist. You see a pulmonologist, and that is actually is the place to get your optimal care. And so you can always reach out to the Cure SMA, and they will help you with the centers closest to you for providing care for adult patients.
Great, thank you. And then one last question. For adults with SMA, are there any therapies in addition to respiratory that would be beneficial to add to a daily or weekly routine?
I think there's a combination of things. I think one would be addressing kind of muscle extensibility or flexibility. And so depending on where you're tight, making sure that you have passive range of motion or massage and stretching, that combination, so that your muscles are in a position to make those gains and they're not working against the tightness. And one of the other things I always like to talk about is kind of trunk stabilization or opening up of the trunk. And so a lot of times it's harder to breathe. If you can just imagine, sorry, I'll share my webcam. If you can imagine where your trunk is, you're hunched over, it's a lot harder to breathe regardless if you have SMA or not. So you want to open up those shoulders a little bit more. And that could be done when you're sitting in your chair and someone can just stretch out these pecs, because that opens up the ribs and gets the breathing going. So a lot of chair yoga addresses that. So I'd really recommend those kinds of things. It incorporates breathing, trunk stabilization, because you need a stable base in order to move your arms or legs. So it's applicable across the board, regardless of what type of SMA that you have. And so I would say trunk stabilization, depending on how tight you are, the flexibility, and if you can fit in all of those programs, strength, balance, flexibility all together. I know that's a bit generic, but just making sure that when you're doing that, addressing it with your therapist or healthcare provider, so that you're in good biomechanics when you're doing it. It really is about the quality and not using momentum to exercise.
That's great. Thank you again, Tina and Dr. Elsheikh, for your time and your great presentation today. And thanks to everyone who participated and listened in on today's webinar. You will all be receiving a follow-up email with a survey link, and we would greatly appreciate any feedback. We are so thankful for all the support from our sponsors for making this virtual SMA conference possible. If you have any additional questions after this webinar, please reach out to Cure SMA at conference@curesma.org. Have a great day today, and be sure to check out Cure SMA's conference webpage for all the upcoming virtual SMA conference educational and networking opportunities. Thank you all.
Thank you.